everyone? I was going to say, can people at the back of the room hear me okay?
Yeah.
Perfect. Welcome. I was going to say, I'm so happy to see so many people in person after so long from being able to see people on tiny little screens and just not knowing what people actually look like in person and in the flesh. But I'm so happy to welcome everyone here today to our Fuse Research Program meeting. My name is Emma, and you guys will be hearing a lot from me today, but also a lot from my colleagues from Tyne Housing and some of the experts by experience I've had the pleasure of working with. Just before we begin, the event is hybrid, and so all the presentations are going to be recorded and they'll be available online shortly after. In the room, folks that are in the room, we'll be taking photos, and so if you have any issues with having your photo taken, please just let us know and we'll make sure we don't include you in any. For sort of question and answer periods, for folks in the room, we're going to have microphones circulated. The only way people on Zoom can hear you throughout the whole day is if you ask your questions into the microphone. And what we'll do is we'll alternate between questions in the room and questions online just to help us hand out mics as quick as possible. I also wanted to say, I think I'm so happy, but we're welcoming so many different perspectives today. We have folks from practice, people from research, and also people with lived experience. And so with that in mind, I really hope we can try to make today as accessible for everyone as possible. And so if ever there's a word or an abbreviation we use that someone doesn't understand, let us know, and we are going to do everything we can to fix that and answer those things. But also when we're asking questions, if we can keep that in mind, it would be greatly appreciated, as I'm sure everyone here recognizes all the unique experience and skills everyone brings. So I'm going to jump into the first session, which I'll give a bit of a presentation, then there'll be some breakout groups, both online and on Zoom. And then after the breakout groups, we'll have a little bit of a break. For those of us that are here in person, there'll be coffee and some snacks and some networking. And for those of us on Zoom, I'm sorry, you're going to have to run to the kitchen and make a cup for yourself. And then we'll go into our second session, which will be quite a nice interactive one, less slides, which is always a nice break from the norm. And then we'll have some question and answers before another break, and then Steve's presentation at the end. So I'll just hop right into my slides. First session today, I'm here to really tell you about the research project I've done over the last year with a bunch of colleagues in practice and research. And I'm really happy to be able to share some of the findings from that study now. But I think it's really important to start the day off with a story. And so in February 2020, Andy had quit his job and was living with his dad in council housing. When the initial lockdown started, he was scared, but he knew everything was going to be okay because he had his dad for support. Things quickly took a turn for the worse when suddenly Andy's dad passed away. Before he knew it, he was being kicked out of the place he'd called home. Andy had become homeless. He found himself hopping from couch to couch, but quickly ended up in a hostel, and it wasn't like anything he could have expected. Andy started to drink to cope with all of his grief and anxiety from the last 6 months. Unfortunately, Andy didn't know where to go to access support. And the question I have for you is, would you know where to go to get support for mental health and substance use if you were in his shoes, or would you be just as confused? That's really the core of why I went through this research process. And so we set out to understand how people accessed, or in a lot of cases didn't access, community-based mental health, drugs, and alcohol use services during the pandemic from sort of the perspective of people who experienced homelessness. And so when I say we set out to do that, the big question is, how did you do that, Emma, and what did you actually do? Well, I had a lot of phone calls with people in 2020. And so I spoke to 10 women who experienced homelessness and 16 men who experienced homelessness about how they accessed or would have liked to have accessed support during the pandemic. When I use the word homelessness, I use quite a broad definition of the word. And I use something that's inclusive of both what we tend to see of people who might be on the streets, but also people that are staying with friends on their couches or in spare bedrooms. Once we had all that amazing information, I think like a lot of people could understand, we realized that was a lot to digest and there was a lot of information there. So I worked with people who had experience of homelessness, substance use, and or mental health problems to just try and make sense of all that and figure out what we found. And that is something we'll talk about in our session 2 today, which I'm excited about. And so from that process, we learned a lot of things. And so for today's session, I'm really focusing on one element of what we learned, which is all around how people access support from the perspective of people who experienced homelessness. I would say we also interviewed 19 people who provided support, and we're in the process of understanding what that looked like, and we'll be sharing that in due course as well. So we found 3 major things from looking at the information. We realized in a lot of cases, some of those changes that services made quite reactively to make sure people could actually access support weren't always the best for everyone. And a lot of people found a lot of challenges trying to get access to support. And that sort of formed our first theme, which we thought of as inadvertent exclusion. Our second theme really focused on this idea that a lot of people had a lot of negative experiences accessing support or faced a lot of challenges trying to get support. And that created a lot of barriers when they were trying to sort of work on their mental health and substance use recovery. The third and final theme is sort of the more positive one, I like to think. And it's looking at sort of the ways that people felt services could be improved so we could do better to help people who experience homelessness and have problems with mental health and substance use. So this first theme, all sort of around how people sort of felt left behind, had 3 major areas in it, and I'm going to walk you through at a very high level some of those areas now. So the first one is sort of mental health isn't 9 to 5, and if there's any Dolly Parton fans in the room, I'm sure you'll understand the reference there. But at the core, that's the idea that for a lot of people, they felt that they were often overlooked in that during COVID, a lot of services were only offered between 9 to 5. And some of the services they might have relied on beforehand that were available out of those hours suddenly disappeared. And I think, you know, this gentleman explained why that was so important for him, having access to support outside of those normal hours. And he sort of says, it should be open when you're feeling the worst. Sometimes when you're feeling your worst, it's very late, you know? It's dark, and it's dark, and that's when you feel your most loneliness, like after 10 o'clock at night, you know, when no one is around. And I think that ran through in a lot of the conversations where people felt as though they weren't able to get support when they needed it most, and often it was when they couldn't turn to friends or family for help either. The second area, which I think most people will be able to understand quite easily, is that because of a lot of the changes that were made and, you know, social distancing, and I think everyone remembers things just closing overnight and suddenly you couldn't even go into, you know, Oxfam or wherever you'd like to go to the shops. They switched to offering a lot of support remotely, either by phone or on the telephone and online. And that was quite problematic because a lot of people felt that although it was great for some people, it didn't work for everyone. And for those who maybe didn't have access to phones or didn't feel comfortable accessing technology, they felt like they were left behind. And someone sort of explained their example on the slide there. The third area was just this idea of one of the biggest issues people had accessing support was just understanding what support was out there and knowledge of what support was available. And so one person sort of said, once you're in this vicious cycle of sort of homelessness and mental health and substance use, it can be very hard to actually access anything because you don't know who to go to or who to speak to, who to contact. It's just extremely difficult to know what to do. And I think it really shed light on this idea that we need to do better in terms of making people just aware of what's out there. The second set of themes all around sort of this element of sort of barriers and challenges to getting help and getting support and starting your recovery journey had a few areas within that I'll quickly go through now. The first one really focused on this idea that in a lot of cases, the places where people access support, so the physical environment, wasn't always the best space, whether that be for housing or mental health or substance use support. And there was a girl who described it really well, and she was talking about a treatment location, and she said, it's not a nice place to go when you're trying to recover from drugs. They're trying to sell you things outside and inside the building, to be honest. And I think, there were suggestions that you needed space that was quite calming, really relaxing, but also really welcoming, and where you felt you wanted to go, not places that you wanted to avoid. The sort of next area was just something that I think everyone, likely, I'm probably preaching to choir here, is that, a lot of care was quite disjointed, and people felt like they were constantly having to repeat themselves as they moved from one service to another. And I think especially in COVID, people sort of said it was all the harder because there was higher staff turnover, and it just made it challenging for everyone. And so this person sort of explained that in their perspective. There was also this element that a lot of times people felt as though they were being forced into accessing support, and that maybe they weren't ready to get help. And people sort of said, the worst thing you can do is make me access a service. I'd rather you work with me until I was ready and then gave me the support that helped me then. And I think that's really important for a lot of people. The final barrier was just this element that a lot of people felt as though, with COVID, there was this major priority placed on rightfully preventing people from getting COVID and getting the virus. But it meant that some of the other issues people faced likely got put on the back burner, and people felt quite frustrated that they just couldn't access services, and they felt like their needs were no longer important or weren't as important as they would like them to be. The final area, which is quite the positive thing, which I think is always important to end on because I don't want you guys thinking I'm a bit of a negative Nancy, is suggestions on what we can do to make the service better and more responsive to people's needs. And so we had two major areas in that, and I'm going to just quickly touch on them. So the first one was just this element that, for a lot of people, they felt like there was a bit of a disconnect between what service was actually offering and what they actually needed. And people said, part of the issue is that and I remember someone vividly saying to me, it's like middle-class white men, Emma, that are making these decisions about me without me. And I think the big takeaway there is this element that we have such great lived experience that we can work with and learn from, and we should be using that in how we provide our services to make sure we're providing the service that's the best fit for everyone, because that's really what all service providers want to be doing. The other area was really around this element of choice and giving people an active voice in services. I always use the analogy of if you go to a coffee shop and they say you can only have a black coffee and you can't have anything else, you're never going to want to go back to that coffee shop. I think a similar philosophy applies with when we're accessing services. If instead you start the conversation with, what would you like to drink today? I have coffee or I have tea, and what would you like in that? You're giving someone options, and you're giving them the right to say, this is what I would like, and this is what works best for me. And really, the core message we had is no matter how small the decision is, people need to have a choice in their own care and how it's provided. So that was a lot of information, and I recognize 10 minutes is not a long time to go through a lot of that. But at the core, what does it mean? It's this thing that, we as a service learned so much from COVID. There was a lot of innovation, and there was great things people did. People did interactive packages to people's homes. Some people who maybe actually preferred accessing things from the comfort of their rooms or from a phone were able to get access to support for the first time. And there's a lot that could be learned from that. But I also think it really shone a light on some of the barriers people faced even before COVID as well as now. And so really, part of the reason I've brought everyone here today is to have a bit of a conversation on what can we learn and what's the most important messages that we can take away and try and change for the better to make sure that we can learn from quite a sort of challenging experience and take the most that we can from it. So I was going to say thank you. Hopefully that wasn't too much of a bore for anyone. And for those of us that are in the room, we're going to break out into little groups. And within each group, there's going to be someone that's going to facilitate a conversation. For those in Zoom, it'll be the same process. And what we're going to do is we're just going to reflect on some of that conversation I've just sort of shared with you and some of the experiences we've shared, and think through what we think are the 2 or 3 most important messages from that, and what are the 2 or 3 most important things that could be done to help make things better for people. So I'm going to stop talking and I'm going to turn off the mic and let everyone break into groups. For those of us on Zoom, when the breakout groups are done, you'll just go straight into the break. And for those of us in the room, you'll just rotate into the next room to grab coffee and tea. Thank you. Oh, I think I'm mic'd up now. Hi, everyone. If we could just all regroup, we're going to start the second session now. And apologies, we're running a bit behind schedule. We're going to try and catch up along the way. But unfortunately, I think that's part of doing things in person is it just takes a lot longer than I think anyone ever remembers. So I'm joined today by two amazing people who I've had the absolute honor and privilege to work with alongside sort of three others as well over the last year. And so they've come today to tell you about the experience of being involved in research and just being involved in the process of understanding the information and sharing that broader. So with the study I spoke about earlier, since I think it was March 2020, Joanne, Des, Tony, and Jeff, and Fiona have sat with me along this process through too many Zoom calls, too many in-person coffee dates with way too many cookies and cakes for any of our waistlines, to try and make sense of everything we learned and do it in a way to make sure we weren't missing anything. I think as researchers and people in practice, often things that maybe are obvious for people with lived experience aren't so obvious for us. And so it's really important that we work with people with lived experience to understand their perspective on what's important and what people are sharing. So Joanne's going to start us off, and she sort of prepared her little spiel on why she got involved, what she's learned, and what she hopes others will learn from hearing about her story. And then Des will go on afterwards.
Right. Shall I stand up?
You can do whatever you'd like.
I'll just sit down. I'll just sit down.
STC, that means that STC.
But I've prepared a bit so that I don't forget what I'm saying. I became involved in the research of homelessness, mental health and substance misuse because one of my family members in 2018 died of drugs and alcohol, and also other family members are also alcohol dependent and have mental health. And also myself have been homeless. Co-production is where I became involved with services to help influence the way services are run and to help change things for the better. Collaboration means working with someone to produce something. We did this in the research by listening to what others had to say and producing the findings. I read the transcripts, commented on them and made sense of them. This I really enjoyed as it gave me an insight into what others go through and not just myself. I have learned from the experience that everyone is important and everyone's opinion counts. I have also learned about sense making, producing the findings, getting our work in the Lancet and becoming a co-author. Very proud of this. I liked everything about the experience. I had not done this before, and being included all the way through was fantastic. I am involved with Fulfilling Lives, ABE, Crisis, Groundswell, National Expert Citizens Group. What would I want other researchers to know if they want to work with people with lived experience would be to include us in everything. Look how far we have come and what we have achieved with Emma. Without her, I would not have believed in myself. I would not have achieved so much. Thank you for the experience.
Thank you. You're great.
I'll just use Joanne's notes. Yeah, I'm Des. I'm a person with lived experience, and just echo what Joanne said, you know, kind of, I would have been described as a person of hidden homeless at the time of March 2020. I was involved with Fulfilling Lives, and you know, for the very reason I got involved with Fulfilling Lives, you know, for the EBE was exactly the same reasons I wanted to get involved with this piece of research and work, because I was at the time experiencing homelessness addiction and mental health issues. So it's only seemed very natural, to help co-create and be involved with the whole co-production process of system change for people that were experiencing it, like myself. You know what, from the moment we first met Emma, who when she came along to the EBE and told us about the work, it felt it was truly co-produced to where we are here today. Everyone that was involved brought a different dynamic to the research. Some of it I've personally found challenging, kind of the transcripts. Emma was always on my tail for basically kind of getting the basic kind of transcripted notes back to her, which I didn't fulfill. But you know what? Everyone brought something different to the process, and when you see the poster and everything that's being done around it, I'm very grateful to the EBE, everyone within the network, Fulfilling Lives, the National Expert Citizens Group, like Joanne. Today I'm a homeless health peer advocate for Crisis. And I wouldn't be sitting here today, kind of being part of this if it wasn't for the likes of the EBE, Fulfilling Lives, Crisis, the National Expert Citizen Group, but most importantly, the recovery community that basically allowed me to embark and be kind of where I am today and to be able to kind of give back and help others. So, I think it's through that continued practice to be involved, to know that if we want system change, we want, services to improve, it's both sides of the fence, because through my own experience of negative engagement with services, because I just wasn't ready, we have a phrase that we call, that road to recovery, and then the road in recovery. And like, it was said this morning around, not everyone's ready, but knowing when a person is ready to be person-centred and to ensure that our voices are heard and it's not lost in translation. And that's what this truly feels like. And I just hope it continues to move in that direction. That's me. Thank you.
You can stay. You've got to stay up here with me for at least a bit longer. You can't leave me hanging. So I was going to say what was really nice about this work is, as we sort of said, we've gone through the process of understanding the information together, but we've also been fortunate in that we've been able to sort of work together to create how we share the information. And so on the slide, which everyone can see in the room and you can see on Zoom, there's a little QR code that you can scan on your phone, which I thought was pretty nifty. That takes you to the site on our study funder, who's the School for Public Health Research through the NIHR. And it lists all of the different outputs that we've done together. But also, this is one of the 2 posters that we designed together. And we worked with a company, More Than Minutes. And it was one of the experts by experience that we work with who had seen some of the work they've done in the past that said, Emma, let's do this. And I said, okay, I don't know what we're doing, but let's go for it. And so we've been able to design posters, and you can get those online on the website for free to print out. You can distribute them as you see fit. For those of us that are in the room today, I have physical copies in A2 and A3 size, and I would welcome anyone taking them and putting them up in your organizations. I was going to say we now have a bit of time for some question and answers. And so I'm just going to sort of open the room up and see if anyone has any questions they have about how you work with people with lived experience to do work, whether that be research or practice. If you have any questions for Joanne and Des about the process, any questions for me about how we've gone through it, I'd welcome any queries online or in person. Now we can just have a bit of awkward silence while we wait for a hand. Chris's hand's up. We'll get you a mic in just a second, Chris. Yeah. Thank you. I'm doing double duties. It should be on.
It's a question for either or both of you, and it's just from the analysis of the findings, what do you think the one thing is that could happen, that could change, that would make things better?
For me, I think it'd be kind of better joined up services, specifically around drug and alcohol treatment services and mental health services and housing services, because it's very fragmented, as we all know. So I think there was some great learning and practice came out of the pandemic, but it's very quickly going 180 degrees again, back to where things were before. So we've got to ensure that the good and the bad, what was learned from the pandemic and the good practices, steer within it, to improve the service for everybody.
Great. Do you have anything to add, Joanne?
I would just say, I suppose recognising that hostels, I would say, they're not always right for everyone. And I would say some people's better off in hostels, some people's better off in the community. And I think it's what's right for them.
Yeah.
Not what you think's right, because I think a lot of the time them decisions are took away from them because that's all they've got. And I think that needs to change somehow. Yeah. So I would do that. I would change it like that, mate.
Great. Thank you, guys. I couldn't do anything better. Do we have any questions online? No? Perfect. Over to you, Beth.
Hi. Just a question for the experts by experience. I'm about to start up a co-produced project at the moment, and I wondered, what was your favourite thing about being part of this project? And also, was there anything that you found challenging?
I loved every bit of it, mate. I liked the cakes, whatever. Cookies.
That's a good tip.
She included us in everything, and I think that was important. Like include us in everything because we felt just as equal. Mm-hmm. And I think that's why she got the best out of us. Mm-hmm. Somebody else might not do that. Mm-hmm. So I think that was why we got so far, I think. Yeah. So it was, I liked the research of it, me. Reading transcripts and going through them and making sense of them. I like that. I like writing, so I was in my element there. Yeah. What else did I like? I found it a bit challenging, the last bit of it. Like when we were putting it all on the...
Putting it all together.
That was a bit... Seemed to have lost it by that point, but I came back in again. But that was it. Yeah. What about you?
I think the sense making was one of the kind of, for me, probably the best part of it. I found the transcript side of it, reading the transcripts and doing it collectively all together, I was absolutely fine with. But doing it on my own, I did struggle with that. But I think through that sense making and what came from how that was done and how that's been actually transferred into another piece of work that Fulfilling Lives are doing, around the adept work, that came from this, how well it worked. I think the co-creation throughout, everyone was, brought a different dynamic to it. How person-centered Emma was, she understood people's individual support needs, and she was very, compliments and hats off.
On the ball, wasn't she?
Yeah, from start to where we are today. And I think, coming to where we are today with that, I really enjoy, I do like anything creative. And I think there was so much more came out of this that obviously couldn't be done just due to the time frame. But, that's not to say that it can't happen in the future. I think there was just some great learning came out of it on how things can be done in this way.
Yeah. Thanks, guys. Yeah. I was going to say we probably have enough time for one more question. If there's another one, I can't see any hands up. Oh, is there one online? Oh, there's one online on the floor. Sorry, on the screen on the floor. So we have a question online, which was, what are the main objectives going forward to put the research into action? Are there any initial or obvious gaps that have been highlighted straight away? Well, Craig, you went for quite a killer last question. I think, it's a really good question. And I think, moving forward, what we're trying to do is do things like this workshop today and just try and share what we've learned. And you can see we're doing that through a variety of different ways. The workshop is one, we've created posters as another. There's sort of the more academic papers, which if you'd like to read, kudos to you. I will not hold you personally, though, if you choose not to read them, because they are quite long. But also doing some reports. And the session this morning, when you went into the breakout groups, I'm going to be stealing everyone's notes and trying to create a bit of a summary document at the end. I think research moving forward, this was only ever the beginning, and I think it's really, for me, shed light on a lot of other areas that I want to unpack a bit more and learn a bit more. And I think, I'm fortunate in that I've met some amazing people along the way, and I'm working with those people now to figure out what we do next and how we do that together. Because I think having done this process, I probably wouldn't change anything about it. I might tweak a few things, but working with sort of the 5 people who've put up with me for the last year and helped with all of the slang words I didn't know because I'm not from the Northeast, and just helped me get through the process, has made me realize I couldn't have done it without them. And I think that's my learning for me, is any research moving forward, I'll be doing the exact same thing with amazing people to learn from. So with that, I'm going to let us all take a bit of a breather, and we'll go have another break, because we all like breaks. And we'll come back for around 11:05 for our last session, which is Steve. For those of us in the room, there should be some snacks in the other room. There'll be other snacks as well after Steve's session, lots of food. And please help yourself to posters and just have a good time and chat away. Hi everyone, welcome back. We're coming to our last session of the day, which I think is one of the best ones of the day. And I'm excited to welcome Steve. And Steve is the CEO at Tyne Housing, which is an amazing organization locally in the area. And he's also a non-executive director for Northumbria NHS Trust, or Northumberland. I can never remember which one it is with that. I'm just going to hand over the floor to Steve and let him take it away.
Thank you. And thanks for the invitation. I don't get invited to these things very often, so that's nice. And thanks to all of those great inputs earlier on, the experts by experience. Just a real privilege and a pleasure to hear from you direct. So thanks to Joanne and Des, and also really pleased as the boss at Tyne Housing to see Carl and Barney and Paul with us today. David, sorry. So basically, I kind of, as Emma said, I've got a couple of hats that I wear here today. The boss of a housing association. I've been a provider of services in this sort of sector for over 20 years, as well as being a commissioner. So I've seen it from both angles, and now more latterly been appointed to the board of an NHS trust, and I've been recruited especially to drive their attention on health inequalities, which is really interesting, but really kind of awe-inspiring, because the NHS and everything around the health and social care sector is just so huge and vast, and it's really hard to understand how we engage with that to make the stuff at a practice level work for people who need services. So fundamentally, I'm a bit of a join the dots kind of person. And I think it's obvious now from listening today that what we sometimes see as homelessness is actually just a small bit and sometimes a manifestation of other things that have been a challenge in people's lives. It's much more about addictions, traumatic experiences, family separation, bereavement, loneliness and isolation, and generally people going through difficult times and struggling to access the kind of services that would help them to make progress in their lives. So I don't see it really as a housing issue for certain, you know, even though my core business is running a housing association. It's really about social care, health, but I think it's beyond that. I think it's actually about how we help people to connect with their communities and all of the support that exists beyond those things that the NHS or the government feels obliged to commission and set up. I think recovery, the mental health and homelessness issues are much wider than the stuff that we provide as services. So I hope that's clear on why I'm interested in health inequalities. And, you know, to put it into a strategic perspective, you know, with one of my hats, I mean, the government is very, very committed to bringing closer together the worlds of health and social care. We're all paying more tax as a result of that. Believe it or not, an extra 1.25% paid on top of people's national insurance contributions. And the idea for that is, over the next couple of years, they'll be spent on the NHS to catch up with what's gone wrong over COVID, but then it all gets pushed into the social care world. Do I have any hope that that will actually touch upon any of our lives, at least for the time being? Not really. A lot of that will go into, you know, catering for older people, going into care homes. There's massive issues around dementia and how we look after people as we keep them alive for longer. There is absolutely no chance, actually, that there'll be extra resources, in my opinion, coming to help us deliver the kind of services we're talking about today. So that's really important to bear in mind. We're not going to get any extra cash to deliver this stuff. So it really is important to tell the story well and to tell the story about what it is that is wrong with current services that we can change to make better for the people who need them. One really important thing I want to flag up, though, from the NHS side is they have given me some hope that they've launched this major initiative across the country, and in typical NHS style, they've called it a really impregnable, ununderstandable kind of slogan. It's called the Core 20+5. Snappy, right?
Is that your idea, Jack?
Well, he's the man to get. But what's really important about that is it is a national initiative, and it does a very broad brush thing. So it targets some resources at the most disadvantaged 20% of the national population. So that'll be very, very broad and vague. But locally, it's going to ask NHS providers to really have a plan for how it meets the needs of what they call the inclusion health group. And that includes people who are experiencing homelessness, people who are living in coastal communities, people who are suffering with drug addictions, people experiencing the criminal justice system, people experiencing mental ill health. So you can see that if we understand that context, we might be able to understand where the NHS is coming from, where the health and social care sector is coming from. And to be honest, badging it around homelessness is probably not the thing that will allow those services to be provided in a more useful and meaningful way. We have to get the terminology right, that it's not a homelessness issue. There are a range of health issues, health inequalities issues that we're seeking to address here. So just a little bit about, it said hopefully, there we are, my approach to this. We've launched a strategy called Putting People First, which completely aligns with what Emma's and the team's feed approach has been. We've heard all about a person-centred approach. It has to be a much more individual kind of approach. And that is much easier said than done, I think. It's safe to say. The organisation's been going for 50 years in this area, and its focus at that time was single, homeless and isolated people. Well, 50 years later, nothing's really changed. I'm really proud to lead an organisation that is still focused on a group of people who are still quite underserved by all of the different strategies and government policies around. But what was interesting about this is it was done at the same time as Emma was carrying out the research that we've heard from today. It was all done in the midst of a pandemic when lots of services were closing down. And the really important and interesting thing for me was that it made the strategy better for that, because it meant we had to work harder to engage with people, to get their views and opinions and really listen to what people needed in order to try and build a strategy that was going to work for the people that we're here to try and help and support. So what we've ended up with is a housing association that's got 4 key themes, and housing's only one of them. Housing, well-being, community and learning. And I think those 4 themes were equally important to us as an organisation and to my board when we set off on this journey of delivering this strategy over the next five years. But I want to say that this isn't one of those strategies which is about securing more and more income or growing to be the biggest and the boldest and the best and taking over the world. It actually falls absolutely out of the needs of the people that are here with time that are asking us for help to get to a better place. And some of these statistics I'll read out might actually put this into some context. So this is based on English data, Office of National Statistics. And first of all, please consider the profile of residents that Tyne Housing currently accommodates. So over half are aged between 40 and 60. 93% are male, and most have experienced exclusions, and in most cases, a multiple range of exclusions from services that should have been there to help them. So that's who lives with Tyne right now. So here we go. In the latest data release, the Office of National Statistics report for the 7th consecutive year that the North East has the highest rate of any English region for alcohol-related deaths. And in particular, males aged over 45 were overrepresented in the figures. It's really a depressingly similar picture with drug-related deaths. Basically, you're more likely to die of drug-related poisoning if you're a male, aged between 45 and 49, and live in the northeast of England. It's the highest rate of drug misuse of any English region and has been for 8 consecutive years. And then finally, the one that's possibly the saddest of all, it's the same northeast picture. Ages between 45 and 49 have the highest rate of suicide, and that's for both genders, both male and female. And suicide in England, for suicide in England and Wales is 3 times more common among men than it is amongst women. So I'm thinking, I've got this profile of residents, and I need to be able to respond to the needs that are in front of me. And that's why I make no apologies for this kind of single-minded pursuit of trying to deliver this strategy against those aims of housing, well-being, community and learning. Because when we talked to people during this strategy, this was the things that we were told were going to help. It was really great. I think I spoke to Des and the experts by experience at one point during the consultation, and certainly the Tyne Residents Consultation Group absolutely informed all of this. But I do wonder, do those figures surprise you at all? They don't really surprise me because I've been working at Tyne for long enough. But I do think it's not widely accepted, and it's not widely known that this is a group of people who are really underserved with accessing the right kind of health and support services. I might not be surprised, but I do find them shocking still. So we have to ask ourselves, will this get any better or will it get worse with the current circumstances that we find ourselves in? Well, I think you probably know the answer to that question. In times of a recession, all of these circumstances get worse. The addictions rise, criminal activity rises, problems with mental health and people feeling isolated and excluded will rise in the current circumstances. And if we know that there isn't any more money out there to help us respond to these issues, it has to be on us to think, well, how can we influence the funders, influence how the money is currently arranged in order to provide the services better, and how can we connect people to other services beyond, as I say, those commissioned services, and look beyond things like the recovery community, look beyond the homelessness services that are commissioned to provide services, and actually connect people more tangibly with the communities that are out there, which will provide people with greater support. So you can see at Tyne why we're really keen to influence the partners and engage with partners to address health inequalities. But it's not going to be necessarily by asking for funding. It's going to be about aligning our hopes and visions with other providers, with other services, whether they're big charities, small charities, or just user groups of all shapes and sizes, because the most important thing is that we have a shared vision for what we're trying to achieve. And the partnership should be based not on income, but it should be based on shared outcomes. It's that shared vision of what we're trying to achieve together. Here's just some examples of things that I think prove that we do work in partnership and that we do learn from what we're being told by users of services, but it also flags up, I think, some of the key issues. So the first one on the left there is this bus called Melissa. It's got a name. And it's something that came out of a project called the Newcastle Collaborative Project, where a lot of people come together and identify what they could do collectively to address health inequalities. So I think it was a couple of weeks ago in May, it went to Old Eldon Square. Some of you will know that as the Hippie Green, and parked up outside and had multiple agencies working on it, including the likes of the Hepatitis C charity, I know the Hepatitis Foundation, I think they're called, ourselves, Changing Lives, all involved in providing this service. And it was an interesting experience. There was 20 people tested that wouldn't have otherwise been tested for hepatitis C, and 10 people were actually found to be positive. 10 people that didn't actually... Out of 20. So it shows the value in some of this sort of thing. But it's a one-off. It was time limited. It might never happen again, but it was an interesting pilot. And we see that over and over again. Good partnership work often comes up with good pilots. The picture on the bottom there is a new house that we've opened called the Recovery House. This was based as a direct request from our resident consultation group to find a way of allowing an accommodation option to become available for people who are ready to become abstinent as part of their journey out of addiction. And we've heard today already that that journey can be quite long and involves a number of stages. And one size doesn't fit all. As you say, the thing about hostels not being for all. You're absolutely right for some people at some points, but actually wrong place for some people at other points in their recovery journey. And how do we provide enough access to services to enable people to get into the right place at the right point in their path? One of the things that we found when we asked the experts by experience during the consultation, somebody said to me, and I can't remember who it was that recovery house is great, Steve, please do put that in your strategic plan, but it won't work unless you have a clear sight of the need for activities, purpose, to relieve the boredom, to allow people to have other things to focus on than just, that the abstinence and the clinical side of things. That's why we've got a nice picture there of Carl playing table tennis in our progression hub. And I've used the one at the top there, which is just to remind Emma that she took part in goat walking. Those two goats, one's called Robson, the other one's called Jerome. And my understanding is that it ended up being the goats taking Emma for a walk. But yeah, no, goat walking is available at Oosburn Farm. Right, I'll move on. So yeah, there's a lot of lessons to learn, and I think we do have to say it's not just about learning the lessons, but it's also about learning about the lessons of how this whole research was approached. Person-centered, people first, however we want to describe it. It's given people the trust and the ownership of the program and the process. And it was great to hear how well you thought Emma did, and that was our experience as well at Tyne. It really involving the people as true experts in their own experience. So these are the emerging themes, and I think are we starting to run out of time, Emma? So I'll leave it at that. I've got a whole bunch of stuff that I could talk about, but these are the themes that we've identified. Inadvertent exclusion. We all know that people suffer exclusions from services. Sometimes that's deliberately and quite, harshly done in terms of policy. But they're also with the best intentions, as many organisations wanted to include people. Inadvertent exclusion was an experience of the pandemic. I'll give you one example of that. I was asked, there's a pot of money, it was all part of the Street Zero initiative that you may have heard of. What can we do to help people through the pandemic? Steve, I need a one side of A4, tell us what you need, and I need it by Thursday. Today was Tuesday. How can you produce anything in those kind of timescales? So I thought, well, let's go for counselling. We've got counselling services funded, could be via telephone, online, or in person at the Joseph Cowan Health Centre. But there were really poor take-up. And part of that was because, A, we weren't able to advertise it well enough. B, we weren't able to ask the questions about how can people access this service easily in their own homes. Have they got the kit? Have they got the connection? Have they got the capability to use IT and access services in that way? And surprise, surprise, some of it got taken up, but not nearly my hopes for what we could have achieved for it. Barriers to recovery. Absolutely, I'd take on board all of this stuff about spaces and places. We definitely need to recognise that putting lots of people together on a recovery journey into one place is not helping that journey. And we need to find a way to break up those spaces and places. I say spaces because it's the environment, does need to be positive, but also the places, different parts of town altogether. People need to have access to services that they feel comfortable going in. Systems that respond to needs, absolutely loved hearing about the work from the experts by experience. I've mentioned that, our resident consultation group instigated the recovery house. That never goes wrong. We really have to learn to trust people to design the services that meet their needs. How we do it, I think, is really challenging. And particularly, I think we need to influence funders to allow the time that it takes to do that in a meaningful and proper way and not force us into rushed funding applications. And absolutely, the stuff about digital exclusion is currently at the top of my list. And I'm currently working with one of Emma's colleagues on hopefully a new piece of work which should just be as involving as this one, which is about how do we really map out the services and make that readily accessible to everybody, regardless of whether they've got the right kit, the right connection, and the right capability to use it. It is about providing one version of the truth. Through the pandemic, lots of services closed down and never opened back up again, but also new services that popped up that nobody had heard of before. And it needs to, this service directory needs to be a dynamic, ever-evolving piece of work. So there needs to be one version of that truth that is stored in an IT place, but accept that people need additional help sometimes just to be able to access that. So we'll never lose, I don't think, that person-to-person contact having people to help you navigate through services and access that information where required. But absolutely, that's only part of what my response is to the research. The main response is to more or less shut up and listen. And that's what I've been trying to do today. Really interested, as in Emma, is in getting the feedback from all of the flip charts and putting that stuff into genuine practice. And from my point of view, I'm keen to stay involved if we are going to continue this work, to really start putting some of the specific things in there, because at the minute I'm finding there's quite broad ambitions about services need to be open beyond 9 to 5. Well, yes, but what kind of services? Is that about counselling? Is that about helplines? Is that peer supported? How is it different to the Samaritans? I just need to know all of that stuff in order to help release some of the opportunities that comes from this experience to learn from the pandemic. With that, I think I'll hand back to Emma and we'll take some questions.
Thanks, Steve. So if anyone in the room has questions, you can raise your hand. I will run over to you with a microphone. And if there's anyone online, just put it in the chat and we'll find a way to see it so that we can answer that question as well. Des, yeah, give me a second.
Yeah, so it's about, you talked about funders, and obviously there was a big part of your presentation around drug-related and alcohol-related death. And you also mentioned national statistics, okay?
Yeah.
So in 2018, it's widely available, through national statistics of the cost of alcohol-related death overall, versus drug-related death, right? And there's a £10 billion difference. 20.8 billion for alcohol and 10.8 billion for drug-related. So the question around basically kind of moving forward, because obviously within that, it's multifaceted, isn't it? It's not just around basically direct drug-related death as suicide and all the other things that kind of come into that. How do you see, basic kind of from, at a housing association with recovery houses, do you see a basic blueprint for replicating that and widening that moving forward with the strategy?
Okay. And well done for multitasking. That was impressive. I've never been able to answer a test message while talking on a microphone. That was very impressive. I don't know is the honest answer, but I know the important thing is that we have to, and this would be one of my main requests out of this group today, is that we use this opportunity as a platform. We use this opportunity to talk to the people who do make those decisions, to try and influence. And I can, I've got various positions of influence, and I can bang the drum. I think I can bang that drum even louder when we do it collectively. And I think having the voice of experts by experience, people who've experienced recovery pathways, who understand, what that means in practice, to have an underfunded alcohol recovery pathway where there's a lot of attention goes on the criminal justice side of things in terms of the drug recovery pathway. It's absolutely crucial. So I'd really like us to be able to, as I said earlier, getting into that detail of what is wrong with the current system. We accept that there may not be extra cash around, but what's wrong with the current system and how might we rebalance it to focus on the needs that we really think are out there, is given more credibility because it's people like me speaking with experts by experience to try and influence. But one of the things I have to tell you about that recovery house is that, we did a survey. Our resident consultation group created 5 priorities for us to write into the strategic plan. And the top priority was digital exclusion. So that was easy in many respects. We managed to get Wi-Fi in every one of our supported houses during the last 18 months. I think that was something like half of the people that we asked wanted that. 15% of the people said that what their priority was the recovery house. So we went for that. It's not full. So I take on board what you're saying. You know, how do we grow it? How do we do more and more of that? But you know, getting the referrals in for people at the right stage in their recovery journey has proven elusive, I have to tell you. And we need to find better ways to get the referrals in for that kind of service, because once that service proves itself, so to speak, it's much easier to replicate it. But I do think the nuances of where people are at different points in the journey is the key thing there. And people really need to understand, is this service going to meet my needs now? They don't always have to be full. I don't think that at all. We need to have enough vacancies there so that when somebody is ready to make that jump towards abstinence,
Do you think it should be about
it's there.
being ready, or like my nephew died of drugs and alcohol and he was 27 in 2018, and I asked for help for him, and they turned around and said he had capacity, and I believe that's why he fell through the net, because he wasn't engaging.
Mm-hmm.
And I think people need to put more work into getting them to engage. Otherwise, they fall through the net, and then you've got drug-related deaths on your hands. So
Yeah.
I think, to me, there needs to be more work in recognising when they're at risk the most. Do you know?
Completely agree. But I think that's the biggest challenge, isn't it?
Yeah.
It's how to help people who aren't yet admitting that they need help.
Build the trust
That's the
up
challenge.
with them.
Yeah.
That's the most important thing, I think. Build the trust up with them. Get to, I'm not saying be the friend, but get to where they're learning to trust you,
Yeah.
so that they can then begin to make changes. I think that's important.
It's so frustrating. I'm sorry to hear about your loss. This date for this meeting was going to be a month ago or so, wasn't it? And it got pushed back, and I was quite pleased that it did, because it allowed me to attend a funeral. It allowed me to attend a funeral of a guy who I've known since I was a teenager. We hung around as a group of friends for years. Now, he didn't ever think he needed help. He did used to use drugs as a younger man, but he stopped doing that because he started having heart problems as he got a bit older. And he would never have thought that he needed any assistance. I know him so well. I know how he would have responded to somebody going up to him saying, do you need help? COVID hit him because he used to make his money to feed his various habits by selling quilts. He used to drive around the northeast with a transit van, and he used to have quilts in the back, and he'd go to every factory, and he was a right hustler, and he would get enough money. And, he never needed to access any help or any support. COVID happened, factories closed. Who's he selling his quilts to? And I tell you what he did. He just sat basically in his flat and drank himself to death. And he wouldn't acknowledge that he had a problem, and he was very bullish about it, and he was pushing everyone away, saying, oh, no, it's fine, it's fine. And you knew he was drinking vodka at 9 o'clock in the morning. I don't know what you do. I do, but I think you're right. We should at least try, and we should have enough doors that are ready to be opened as soon as somebody's ready to knock.
I've got a twin brother who's also alcohol dependent, with another brother who's also alcohol dependent. And he's been drinking for 30 years, been going through the same circles. So to me, everybody gives up on them.
Yeah, yeah.
And it becomes where they don't want help, or they don't trust people. So to me, it's about going to them, because they're not going to come to you,
I was going to say, we've got one question online, and this will probably be the last one, so I'll read it out because I feel like the font's quite small. So it's from Hannah, and it says, "Hi, Steve. As a previous housing sector worker who's moved into health and substance use, it was really refreshing to see the collaboration and whole system work with the NHS around health inequalities. How did you get into your role with Northumbria NHS around health inequalities? And how has being in this role benefited your work within housing?"
Okay, well, I've only been there since February, so time will tell. But the truth is, I was approached. And so this is maybe a good example of what I was saying about the NHS's commitment to addressing health inequalities. I think it has understood the problem and it needs to do something about it, whether the money will ever follow that and make it into a more preventative arena is another matter. But for me, there are far too many people who I work with and have worked with over the last 20 years whose first access of the health services is under a blue light. They go in there under a crisis situation in an emergency, and things could have been done much more proactively, preventatively, and made a much better impact, frankly, than trying to respond. So I've been kind of banging that drum for a while. The NHS have obviously kind of made these strategic commitments, and they approached me. Somebody said, you know, we like what you're talking about. Would like you to come onto the board. So I think that's maybe a direction of travel that shows you that there is some stuff out there going on. We just need to be able to talk to those systems better, and we need to be able to get our message clear and specific, because those health commissioners won't listen if it's not really clear and evidenced and identified. So I think that's the real challenge for us today. That's what I think I hope to bring to Tyne and the wider sector, is maybe that sort of discipline and challenge back to say, yes, you say this, but what about? Because, you know, guess what? There's an awful lot of inequality out there, and it's not just about homelessness, mental health, and substance misuse. There's a whole raft of people out there who need better services and support. And so we've got to be ready with the right clarity of message and purpose to influence change.
Perfect. Thank you, Steve.
I'll just make a compliment, please, towards the yeah, it's just a compliment actually about the you know, the approach. So a couple of weeks ago in Dublin, there was the BIC Homelessness and Addictions Symposium around basically, you know, DLUC and everything there, and all the basic commissioners and services. And that was the big thing that came out of the day, of exactly what you had on your slides, housing and health together.
Yeah.
Because, you know, there was the commission leaders and things like that, and that were basically kind of saying, well, why can't we do this together? You know, that approach, you know, housing first, with housing and health first.
Yeah.
So that's a really big compliment to see that you had it on the strategy.
And that's why we call that strategy people first, because that's what it boils down to in the end. I hate this idea that it's housing having an arm wrestle with health over who gets the money and how should we provide services. It really should be about the person, the individual approach.
So I was going to say, with that, I'm hoping my mic's on. I just want to say thank you to everyone who's spent the last 2 hours just talking about something that I know I'm really passionate about, and I think everyone who's been here today is as well. I think for everyone that's here, whether online or in person, you're going to get a survey in the next 2 days just to reflect on the experience. And it's our first time doing hybrid. It's definitely my first time doing hybrid. And if there's any suggested changes you might have, but also a chance to just have a bit of a ponder and a reflection on what we've learned today and what we've talked about, and see if there's anything else that comes up. For anyone that's interested, you can always get in touch, and we're happy to share anything from today. All of the presentations have been recorded, and they will be put online, and we'll make sure you all receive the link to that as well. And just a big round of applause to everyone that's joined today and helped out. Fuse for supporting and making this day happen. Joanne, Des, and Steve for willingly coming and just standing up here and giving a presentation was something that I am truly grateful for, and I think they added so much to the day. So big thank you to everyone. Coffee and tea and sandwiches in the other room for those of us here. For those online, have a good lunch and enjoy the day.